I'm a general internist. I work at Zuckerberg San Francisco General Hospital, so I work in a safety net hospital and have since I was a resident here in the 1980s. And so I'm no stranger to substance use disorders and opioid use disorder in my clinical work. But most of my day job is actually orchestrating educational programs for anything that leads to or emanates from the MD degree, so medical school, internship, residency, fellowship, and continuing education for physicians. And as an educator, when we look at a problem like the opioid use disorder epidemic, we think first in terms of how are we going to teach people? What kind of coursework do you need? How many lectures? Who should give those lectures? What's the content? And UCSF has for a long time incorporated within the first year of medical school a module on substance use disorders. And so we're not behind the curve with regard to that. But experiences that we had in the 2017-2018 academic year really led us to rethink that approach. And what I'm going to talk about today is not about the number of lectures that we give or the tests that we administer to make sure the students have learned this content. But I'm going to talk about how we came to recognize, and this is relevant to what the last speaker was talking about, that education alone is insufficient to deal with this epidemic, either for new physicians or for existing physicians. What you really need is broad-based systems change. And that system change has to start at the level of the medical school itself, from the day the students walk in, to understanding the epidemiology, prevalence, signs and symptoms of substance use disorder, and also the dysfunctional ways that the medical profession has looked at substance use disorder that are interfering with our ability to provide the very best evidence-based care for people around us. So if you'll bear with me, I am going to talk a little bit about why this became so evident to us. And as David alluded to, it's because we had a student who died, a first-year student who died 4 months into medical school of an accidental heroin overdose. And so I'm going to tell the tale of two young men who I knew, this student who died in November of 2017 and my nephew who died in February of 2018, so just 4 months apart, that really led us to do a lot of soul searching. Soul searching we should have done before this time, but it was the deep dive into the circumstances and systems around each of these deaths that really gave us new insights that I will share with you today. So in November 2017, I was actually on my way to Lake Tahoe when I got a call from one of my deans who said that a student, we had done a welfare check on a student who had been behaving somewhat unusually for the preceding couple of years, and he was found to be dead. With evidence around him that led the investigators on the scene to realize that this was an accidental heroin overdose, injected heroin overdose. And so I turned around and we came back and talked to his parents, and it turned out that this individual, Jay, who's not his real name, had a history of substance use disorder, opioid use disorder, dating back about 4 to 6 years, for which he had been treated, had several close misses, had undergone rehab, had been temporarily on medically assisted treatment, and then had been in recovery or in remission for several years and decided he wanted to go to medical school to work with others who were suffering from substance use disorder. He was a fantastic medical student. No one would have known by looking at him any differently than any other medical student that this person might have been susceptible to an opioid use disorder. He was an excellent student. He was kind to his friends. He lived with 2 other medical students. And a couple of weeks before he died, he appeared in an emergency department having sustained a minor motorcycle accident. He was a very expert motorcycle rider. And was given opioids for some aches and pains that he had at one of his ankles that had been scraped in this accident. Most believe at the time that he had actually relapsed at this point and was using the excuse of the motorcycle accident, a single-person accident, to get more opioids. He continued to do well in school. The couple days before he died, he began behaving bizarrely at home, and his roommates actually appropriately were concerned and got him to call his parents, who were the only ones in this environment who knew he had an opioid use disorder history. They didn't think about relapse as an issue. And they also got him to go to a clinic where he had been previously seen and was under the care of a doctor there getting some medications for what seemed to be minor flu-like symptoms. The next day, the students actually became increasingly agitated but didn't want to talk to administration because they were fearful that, in fact, if they knew there was something wrong with their friend, that he might get kicked out of medical school. This was a common theme we heard, as nobody wanted to blow the whistle because we thought he might be on something, and people get kicked out of medical school for all sorts of reasons. Well, I will tell you, as someone who's been in medical education, I can count on one hand the number of medical students that we've kicked out of medical school in the last decade. And so that sort of myth is out there. He came to school on a Wednesday and took an exam and passed an exam, a very complicated exam, and was seen by a clinician who knew him well, who queried him about depression or anxiety. He denied any suicidal intent, and then he went home and accidentally ingested a fatal overdose of heroin mixed with fentanyl. And so this was devastating, as you can imagine, for everyone involved in his care. And I would say that we spent the next several months doing grief counseling and trauma counseling for our students who were connected with him, who all asked the same questions we did. How is it that we didn't know? What were the clues that we overlooked? And then in February, I got a call from one of my sisters who said that her son had similarly had a fatal heroin overdose, having just gotten out of rehab for his opioid use disorder, an opioid use disorder that had been in existence since he was in high school, and first found OxyContin in a friend's medicine cabinet and started using it to deal with some personal demons. So it really struck me that these two young men, one 23 and one 26, were lost to us with all of their potential and with all of the grief that was associated with the residual people. And yet all of us who had been working on opioid use disorder in our patients were really ignorant with what was happening to the people who were right next to us. And I think that's really one of the tragedies of the way we think about this. We just are not alert enough. We are now, but we weren't then. And in the honor of these two young men, we have really taken some really big steps that I'm going to share with you. You know the data. 174 people lose their lives each day to substance use disorder, and opioids are a big part of this. And that means 174 families and groups of friends are left devastated by that loss. Given the prevalence of opioid use disorder in the United States in individuals between the ages of 26 and 34, which is prime training time for medical students and residents, that means as many as 700 US medical students could be affected by opioid use disorder, or approximately 5 per school. This isn't as prevalent as mental health crises in medical students, but it may be imminently more fatal. And that's one of the things that we really recognized, is the rapidity with which someone who has been stable can actually succumb to this from a life perspective. And as we've talked with our colleagues across the country, 0 medical schools were prepared to deal with a medical student with opioid use disorder. Nobody had existing policies or procedures. We were very adept at managing the crisis of suicidality and depression, anxiety in medical students, pretty adept at dealing with alcoholism, and actually fairly adept even at dealing with cocaine and crack when that was more of an issue. But opioids, nobody really thought about how is this different than any other substance use, and what are the ways in which we actually need to be prepared. And so this is work that we've undertaken and have submitted several articles on as well that are under review at this time. And one of the things we realized in the root cause analysis that we did after the student's death, so after the student died, we worked with his parents and with experts in our environment to really take a deep dive into the timeline of events, and also the understanding that the student had and had communicated to his parents about his environment and whether it was supportive of his recovery or not, and what his parents thought about this. And so we spent a lot of time trying to figure out where did we go wrong and how could we change things going forward. And in our environment, it's known, a hidden curriculum is what's known when there is evidence that tells you, and you teach the students to do one thing the right way, and then around them people are doing things the wrong way. So if there's a disconnect between evidence-based practice and the practice that people see in the environment, that's known as a hidden curriculum. And this is why we realized, we have a ton of evidence about what's the best way to treat opioid use disorders and other substance use disorders, and about what causes these things. And yet, every single clinician that this student came in contact with, virtually from the time he had been diagnosed 6 years previous to the time of his death, behaved in ways, treated in ways that were not compatible with evidence-based medicine, but were compatible with long-standing stigmatized views that professionals have about the nature of substance use disorder and the role of different options in treating substance use disorder. So we're trying to set out to address this hidden curriculum, which usually is inconvenient and distressing for students when they see that they're told to do one thing in the classroom and they see their doctors on the wards or in the clinics do something different. That can cause a certain level of intellectual or moral distress, but in this situation, we believe it actually contributed to the death of this young man. So here's some examples of things that we heard from the patient, the individuals, the students' family and friends about disconnects between what we believe is true about opioid use disorder and other substance use disorders, and what was manifest in the interactions that this student had with both treating clinicians as well as administrators in the school. So we know opioid use disorder is a chronic disease of brain chemistry that's caused by this complex interplay of genetics, environment, exposure, and access to opioids. That's what we teach our students. In fact, this student had just finished a 3-week module on substance use disorders. And this is lessons that all of those students learned, treated by all faculty and clinicians in the environment. And when you think about this, when we go to recruit medical students into medical school, knowing that a medical student has a chronic disease like asthma or type 1 diabetes or rheumatoid arthritis actually enhances their application to medical school, because we think, wow, this person will really understand what it's like to be a patient and will bring unique insights into their role as a physician that can not only help them interact with patients, but may help their peers learn about this and interact with patients. That is not the way we treat opioid use disorder or substance use disorder in the medical school admissions. Opioid use disorder is still by many people seen as a sign of personal weakness or moral problems, and a source of shame rather than a source of strength. And we know this because the physicians who were in this student's recovery group advised him strongly to never talk about his substance use disorder with anyone, whether his peers or with his administrators or with his treating clinicians. Multiple physicians told him this. And in fact, the student made the decision about which schools to apply to based on whether or not there were questions on the application about substance use disorder, and chose only to apply to schools where he was not going to be required to either disclose or lie about disclosing his past history of substance use disorder. We also know that prescription opioid use disorder can affect anyone, and is particularly prevalent in young Caucasian men. And it often begins with a prescription of opioids from a physician for a seemingly appropriate indication. And yet when this young man in the peak age of peak prevalence for opioid use disorder presented to an emergency room with a non-life-threatening minor musculoskeletal injury following a motorcycle accident, he quickly obtained narcotics for this treatment, when in fact you could argue that non-narcotic treatment might have been a more appropriate treatment. We know that substance use disorder often manifests first in dysfunction at home with preserved function at work and school. We know this is part of the syndrome of substance use disorders, that people hang on to their best hours for when they are most visible to other people. And yet when the clinicians were alerted to bizarre behavior, unusual behavior in this medical student, they didn't really consider the possibility of substance use disorder because he was doing so well in school. He was an admired student. He took and passed an exam, and people really asked themselves, this is, maybe he's a little bit flaky, but how is it possible this could be anything other than just normal stress in a medical student? We know that medically assisted treatment therapy is more successful than abstinence alone, and yet clinicians who saw this student in the intervening time between when he first went into remission and then started medical school, never considered the possibility, or at least did not refer the student for consideration of reinitiation of medically assisted treatment in the setting of anticipated extremely stress. Medical students is a high time for stress, and it might have been anticipated that this would be a situation in which closer follow-up at the least, and perhaps more aggressive treatment might have been appropriate. We also know that opioid use disorder in remission is a protected disability under the Americans with Disability Act. And yet clinicians who were caring for the student did not consider and did not refer the student for evaluation of accommodations. Accommodations that would have done two things: allowed the student to have time off to attend behavioral treatment, whether that's a 12-step program or other psychologic treatment or community-based therapy, and did not recommend, and it would also have allowed him in the clinical environment to be treated with medications like Suboxone or naltrexone without any concerns about what would happen for subsequent drug tests. Medical licensure is possible for providers with opioid use disorder, providing they disclose their condition and agree to treatment and monitoring. Treating clinicians who saw this student at the beginning of medical school, and he confided his history of opioid use disorder to them, elected not to enter the diagnosis into the student's medical record, telling the student it would be better because this way there would be no way that the medical board or other administrators could actually find out about his substance use disorder. And rather than counseling him that medical records are confidential, even to medical licensing boards. And this actually turned out to be a very serious error in judgment, because another clinician saw this student the day before he died, and had there been a reference to his opioid use disorder in his chart, might have actually recognized that the symptoms he was presenting with and describing were really quite compatible with opioid withdrawal and intoxication. We also know that the risk of substance use disorder in general in physicians is approximately equal to that in the lay public. And the risk of opioids as the drug of choice is much higher because of accessibility that physicians have to prescriptions. And yet the curriculum that we had presented to this student and that he had just completed never once mentioned substance use disorder in healthcare professionals. It was all about substance use disorder and opioid use disorder in the lay public. And so this contributed both to a lack of understanding on the part of his peers about substance use disorder and the possibility that friends who are behaving abnormally might be on something. But it also actually further stigmatized the student, who really felt, and he had many conversations with his family, that the university was not welcoming this idea that physicians could have issues with substance use disorder. So as we recognized, it is insufficient just to give lectures and just to give tests in order to teach people how to appropriately care for patients with substance use disorder, whether they come from your roommates or whether they are your colleagues or whether they are your patients who have other occupations. And so what we realized is that we as medical schools have an obligation to systems change so that we're prepared to evaluate, identify, and refer for treatment students with opioid use disorder. And in putting in place these systems and talking about them with students at the beginning of medical school and then throughout their experience with us, we actually can change the conversation about opioid use disorder. We can point out what was so startling to us, that you can be a high-functioning medical student, a high-functioning physician, a high-functioning nurse, and still be susceptible to opioid use disorder because you might have that complex interplay of genetics and exposure and access that leads anyone to any chronic disease, whether it's opioid use disorder, diabetes, or rheumatoid arthritis. So I'm just going to run through these 6 critically necessary structural changes that all medical schools should undertake. First is clinicians who provide health care for students, student health or people in health systems that treat students, have to be prepared to manage students with a history of opioid use disorder. And this has been a significant change at UCSF, and we are working with the University of California more broadly to make sure this is true at all of our campuses. These are medically and legally complex conditions, such as opioid use disorder, and it is unreasonable to expect that every single primary care doctor is going to have sophistication with this. But what it is reasonable to expect is that they have ability to immediately refer to an expert, anyone who needs treatment for substance use disorder or who should be evaluated for the potential of relapse in the setting of extreme stress. It should go without saying that when someone discloses opioid use disorder, you should not tell them, don't put it in the record because someone might find out. You should say, this is a chronic condition, just like diabetes and rheumatoid arthritis. It belongs in your medical record. Your medical record is confidential. No one at the licensing board can access this without your permission. And it will be important should you ever come in the future with symptoms that might be compatible with relapse. And schools must have access to intensive treatment for students who relapse. It can't be something that you think about the first time you see a patient, a student who has relapsed from a substance use disorder. Time is life, especially when you're dealing with opioids. Every single time someone who uses opioids takes that pill, they are at risk of death. It's much different than any other drug of abuse that we see. We have to be able to act rapidly, and the only way you can act rapidly is if the systems are put in place at the outset. Whoops. I don't know how that happened. The second systems change. Students with substance use disorder have to be prepared for the steps they will need to take to become licensed. We need to start talking about this from the very beginning of medical school. And not just for selected people, but 100% of people entering our medical schools and entering our residency programs. I gave a talk to the incoming residents this morning about this and said, these are situations that happen. You can still become a physician and still advance in your career if you happen to be the unfortunate person who succumbs to a substance use disorder. But you have to realize that in order to protect patients, you will have obligations. And we should get people started in thinking about that so that they know how the school will support them and how the medical licensing approach will be changed for people who actually end up with a chronic illness such as opioid use disorder. So I think talking to people about the importance of opioid use disorder as a protected disability, and that's how we treat anyone who has a protected disability. We provide accommodations that enable them to become successful in their career, and that there will be a time when they need to disclose this information. So let's talk about what that looks like and how they can best prepare themselves to address issues that arise. This was probably the most important systems change, is that schools should adopt a universal opioid use disorders precaution in dealing with students who are described as being intoxicated or under the influence. As I just alluded to, unlike alcohol, opioid use disorder individuals are at a risk of death each time they use the drug. And so we have to be prepared to rapidly evaluate students about whom a complaint about unusual behavior, potential intoxication, potential substance use is received. And by I mean emergently. The time between the medical school was notified about unusual behavior in this young man and the time he died was 24 hours. 24 hours. No other condition that I have dealt with in my 30 years of being a medical school educator has that much lethality other than active suicidality. And yet we respond actively to suicidality that quickly. Alcoholism, we sort of say that's an important thing, we should get to that, but we don't feel a sense of urgency that it has to be undertaken today or tomorrow morning. And I think that's actually one thing that we have to get across to our colleagues, that has to be the case. All schools should have and widely publicize a hotline that can be used by anyone to raise concerns about student, and response should be an immediate welfare check. We worked with our police department because they also needed to be educated about this. Like, you can't just decide you're going to sign this out to tomorrow's team to go out and check this individual. If there's any chance that opioids could be at play, which means if the student is intoxicated and isn't using alcohol at the time, that needs to be the first thing that you think about. Schools have to develop policies, procedures, and programs for students with opioid use disorder, and the extent to which we talk about these reinforces the lessons that this can happen to anybody in the environment. It can happen to a physician, it can happen to a teacher, to an engineer, to a cop. And the more we get the next generation of physicians to understand how ubiquitous and how democratic opioid use and other substance use disorders are, the more they actually can approach all of their patients with a level of understanding and a level of activity and agency in helping patients counteract this particular disease. So this means we have to be able to rapidly respond to concerns about this. We have to be able to manage students and monitor them, much like we manage professionals. It was shocking to figure out that there is no system in place for monitoring students the way we monitor licensed professionals for substance use disorders. You have to actually design the system, and so we've worked with our health systems to do that. And helping our students understand at matriculation that this happens, it's unfortunate when it happens, but we know how to deal with it, goes a long way to removing the stigma on the part of the students who might be hesitant to seek help. And as I said to you earlier, one of the problems with the students who were around this particular student is they were so fearful that raising the red flag about this student's unusual behavior would lead to him being kicked out of school, that if we had just been talking about substance use disorder from the very beginning, the way we talk about mental health illness, the way we talk about wellness, the way we talk about depression, the way we talk about suicidal ideation, would have made a big difference in their willingness to approach administration in a more timely basis. And we actually have to address this in the curriculum. I put this last because this is important, but we also do this already. This was not sufficient, and the systems changes I just talked about are things that we believe have really increased our effectiveness in educating the next generation about this. I'm sorry, I didn't put it last. I switched those slides. Harm reduction strategies are also equally important. Workplace monitors may be really helpful. So if this student had actually confided in any one of the people who saw them on a regular basis that he had this and asked for their assistance, comforted by the understanding the administration would work with people with opioid use disorder, he might be alive today. Naloxone should be available in all areas where students congregate, and all students should be educated in its use. School social events and housing should include options for substance-free environments. We've actually started offering student matchmaking system that allows people to opt in to a substance-free home rather than that this student actually was not in a substance-free home and could have found one had that been something that we had offered. And there are professions, particularly anesthesiology, where the risk of relapse from opioid use disorder is extraordinarily high, and the risk of fatality from that is very high for physicians in training. Knowing about this and counseling students that there are specialties you should not pursue in the setting of opioid use disorder is appropriate. So I'll just close with a couple of observations. Why is this the approach we're taking in terms of designing the educational approach to educating the workforce for the future? Because we know that lessons from patient safety and quality tell us that education is important, but it is not sufficient. Just publishing articles in the peer-reviewed literature and expecting every health professional who might stumble across somebody who's suffering from opioid use disorder, either with disclosure or without disclosure, is insufficient to embrace or to lead to the type of change in approach that we really need to if we hope to address this epidemic. So it requires systems that actually protect vulnerable patients, those patients that come to us either willing to disclose their challenges with addiction or not willing to disclose, to protect those vulnerable individuals from fallible physicians who might be too busy that day to notice their pinpoint pupils, or who might actually not even be thinking about what's the next step I need to take this student and help them through their opioid use detection. So we need to build these systems around it, and building the systems and publicizing those systems also helps educate the next generation. I will say that the death of this 26-year-old medical student was no more tragic than the death of my 23-year-old nephew. Unfortunately, my 23-year-old nephew didn't have a community around him who could take this same approach. He was not a stellar student. He was not a high potential future professional, but he was loved, and he is missed. And I think these types of interventions that we're taking will help other physicians deal with people like John, just as medical schools are dealing with people like Jay. And I will close just saying with what I said at the seminar that David and Ellison met me at. And that was that all practicing health professionals and future health professionals have to expect with great clarity that refusing to learn about and treat substance use disorders, choosing to not do that, is negligence. There's no other disease that we allow people to opt out of. We don't allow people to say, I'm never going to treat diabetes, or never going to treat congestive heart failure, or never going to treat asthma. We expect that as a practicing physician, you will at least have sufficient knowledge to triage and resuscitate people and get them the help that they need through the right consultants. Treating substance use disorder as a disorder of will rather than a disorder of brain chemistry is incompetence. We cannot accept that people actually, either tacitly or explicitly, communicate to patients that this is a disease that is their fault, that if they were only stronger and stayed off of the medications, they would be fine. That flies in the face of all evidence. And stigmatizing people with opioid use disorder, whether they're a blue-collar worker or a professional, and treating them differently than other patients with other chronic disease is just cruelty. And we as healers who have committed to making the world better for patients and helping them understand how to get to that better world where they're on the other side of active substance use disorder, never want to be cruel. And it's time that we put our actions where our brain is and change the way we think about substance use disorder. So with that, I'll end. I know it's late in the day, and thanks again to Dr. Smith for having me.